Hello, welcome to my channel. So today we're going to go through our second and third week of development. So this is our General Embryology lesson 2 under the Human Anatomy and Physiology. So if you've already done lesson 1, hope you've watched it, because you can't just start from second week to third week without watching the first week. So meaning without watching the implantation week. Okay, so I think let's start. And if you haven't subscribed, please subscribe and hit the bell notification to receive notification whenever I post a new video. Okay, so objectives. So what we are going to learn today is we're going to learn the second week of development. Then next we're going to go to the third week of development, where we are going to learn about gastrulation, formation of the notochord, the fate map, and the growth of the embryonic disc. And also we're going to learn the further development of trophoblasts. That's what we are going to learn. So let's start. So remember, last time we ended on day 7, which is the first week. So today we're continuing with day 8, which is now we are going on the second week. So after, of course, the blastocysts and the trophoblasts, okay. So on day 8 of development, the blastocysts that's partially embedded in the endometrium, which is idmatus and the eye vesicular. That's one of the things we have to remember. Okay. The next is that the trophoblasts, which differentiated, the trophoblasts are going to differentiate into the cytotrophoblasts, which are mononucleated and mitotic, and the syncytial trophoblasts, which diffuse with no cell boundaries. So what you are saying is that under the same part under the same trophoblasts, they are going to differentiate into two types of trophoblasts. Number one, we have the cytotrophoblasts, which are mononucleated and mitotic. The other one are syncytial trophoblasts, which diffuse with no cell boundary. So meaning in this diagram, which is here, the syncytial trophoblasts, which are here, are going to diffuse with no cell boundary. Then the other one, which are the cytotrophoblasts. The cytotrophoblasts, they are going to diffuse actually with a cell boundary. So these ones, the cytotrophoblasts we have seen, they have made a cell boundary, which is here. Okay. Then they are mononucleated and mitotic. Okay. Then that's one thing you have to remember. And then the embryoblasts. So after the blastocysts, then it's going to become an embryoblast after the trophoblasts have differentiated. So the embryoblasts will differentiate into the hypoblast and the apiblast. So meaning hypo, low, then up, api. Okay. So meaning the one which is on the lower part will be the hypoblast, the one on the upper part will be the apiblast. That's what we have to remember. And then next, you're going to know that the amniotic cavity appears within the epiblast. So on the up above portion, that's where the amniotic cavity is going to appear within the epiblast. Then in the upper epiblast cells, they start being called the amnioblasts. So meaning in the epiblast portion, the one which is here, the cavity which forms here, the one where the pointer is pointing. Okay, so the epiblast, we are saying the epiblast and the hypoblast are the one which forms. Then inside the epiblasts, they forms a cavity. That cavity is the one which we start calling the amniotic cavity. Then again, the upper cells of the epiblasts, they start being called the amnioblasts. That's also what you need to understand. So this is the first introduction. This is what happens during the age of development. Remember last time we ended on the blastocyst that's partially embedded in the endometrium. Then after that, then the trophoblasts started to differentiate into the cytotrophoblasts and the syncytial trophoblasts. The cytotrophoblasts are mononucleated and mitotic, and of course, the cytotrophoblasts actually you have seen they have made a cell boundary. They have a cell boundary which is here. Okay. But let's go to the syncytiotrophoblasts. Syncytiotrophoblasts, they don't even have a cell boundary. Okay, so they diffuse with no cell boundaries, if you have seen properly here. Then next, the embryoblasts, the one which of course was the blastocyst, and continued to differentiate after the trophoblast differentiated, it remained and became an embryoblast. So since the embryoblast also is going to differentiate further into the lower part, which is going to be called the hypoblast, the one which is here, hypoblast, this line. Then we have the epiblasts. The epiblast one which is above this, above the hypoblast. Then a cavity is going to appear within the epiblast. This cavity will be called the amniotic cavity. Okay, that's what we are talking about. And then lastly, the upper epiblast cells, we are going to now start calling them the amnioblasts. Remember, from the embryoblast to amnioblasts, meaning the cells that form in the upper epiblast cells. Those are the one which we call the amnioblasts. So this is the 80. Let's go to day 9. Let's go to day 9. Under day 9, what happens is there is implantation site. The implantation site is covered by a fibrin coagulum. Then the syncytium becomes vacuolated, forming lacuna. That's called the lacuna stage. So this stage where the lacuna is formed is what we call the lacuna stage. Then the hypoblast cells migrate along the inner layer of the cytotrophoblast to form the exocoelemic membrane, or the user membrane, but most commonly it's called the exocoelemic membrane. Then this one line is one which lines the primitive yolk sac, which is the exocoelemic cavity. So meaning the exocoelemic membrane, the cavity of the exocoelemic membrane is called the lining of the exocoelemic cavity, the one which is here, this cavity, the one which we have seen. Its lining is called the exocoelemic membrane. That's what we are talking about. Okay, so let's now look at this 79 in the picture. Let's explain it in the picture. So the implantation site becomes covered by the fibrin coagulum. So meaning the implantation site will be the one which is covered by the fibrin coagulum. Okay, so the implantation site is the one which is this part. Okay, you have seen the fibrin coagulum here. So meaning the implantation part that has been covered now. So meaning where the cell had implanted from, and it has entered into the endometrium. Now it's now become covered by the fibrin coagulum. The next, the syncytium becomes vacuolated, so meaning we have the enlarged blood vessels which are here. That's what we mean by vacuolated. So after it becomes vacuolated, then it becomes what we call a lacuna. So this is known as a lacuna stage. So meaning there is vacuolated ear and vacuolation ear. Okay, so this is what we call the lacuna stage. Then next, the hypoblast. Let's go to the hypoblast. Remember, this is the epiblast and the hypoblast. It is here. So the hypoblastic cells, they are going to migrate along the inner layer of the cytotrophoblasts to form the exocoelemic membrane. So the inner layer of the cytotrophoblast, of course, is the one which is the cytotrophoblasts are here. So these ones which are here, this yellow line you are seeing here is what we call the exocoelemic membrane. So it's going to line the cytotrophoblasts. Okay. After it lines the cytotrophoblast, remember what we are going to remain with is the sac, or the cavity. So this cavity is known as the exocoelemic exocoelemic cavity. Also, other name is the primitive yolk sac. The primitive yolk sac. So basically, this is what happens during the 9 of development. Okay, this is what happens during the 9 of development. Let's go to the 10. So under the 10, there's going to be surface defects, which almost entirely is healed, and the blastocyst forms a protrusion. So in addition to the death of the reaction, which is the polyhedral cells are loaded with glycogen in edematous tissue. Then the lacunar network forms, then therefore the syncytial cells penetrate deeper and erode maternal capillaries, forming sinusoids to establish uteroplacental circulation. So, okay, let's now explain with the diagram. So, remember we ended on the 9 where we said, okay, the lacunas have been formed. Now, remember those lacunas have to serve a purpose. Okay, so the lacunas were just individual lacunas. I'm sure if you saw that previously, they were just individuals. They didn't form a network. So it's going to be a surface network that almost entirely is actually healed, and the blastocyst forms a protrusion. So they're going to protrude to go towards the lacuna. And of course, in addition to the dose reaction, meaning in the endometrium, where the polyhedral cells are loaded with glycogen in mother's tissue. Next is the lacuna network formation. So meaning those lacunas which were occurring as individuals will actually connect to become what we call the lacuna network, the lacuna networks. So this is where we have the syncytial cells. So remember the trophoblasts were divided into the syncytial trophoblasts and the cytotrophoblasts. So the syncytial trophoblasts are going to penetrate deeper and erode the maternal capillaries. Then they form what we call the sinusoids. So if you have seen the sinusoids are here, that's when they are formed. If you have seen this is the lacuna, this is the lacuna, it's like they have now connected, they have been penetrated and they are now connecting together. So those ones are maternal capillaries which form the sinusoids. Why do they do this? In order to establish a uteroplacental circulation. Okay, so that's what happens during the 10. Okay, so during the 10, this is what's going to happen. So that's the 10. So let's go the 11 to 12. So remember, the yolk sac cells in this stage, which are derived from the hypoblastic cells. Remember, we said the hypoblast cells, those are the one which actually forms surround the yolk sac. So the yolk sac cells, which are derived from the hypoblastic cells, fill the space between the cytotrophoblasts and the exocoelemic membrane. So after that, it forms the extraembryonic mesoderm. It forms the extraembryonic mesoderm. Okay, that's what we are saying. Okay. The cavities in the mesoderm join to form the extraembryonic or the chorionic cavity. Then this is when we have the somatophoric and the somatophoric and the sprachnophoric mesoderm layers are distinguished. So now let's start with the explanation with the diagram. So number one, we say that the yolk sac, which is the exochoremic cavity, is the primitive yolk sac, has of course cells, and those cells are derived from the hypoblasts. So the hypoblasts is the one which actually, this is where we got the yolk sac cells from. So they start filling in the space between the cytotrophoblasts and the exochoremic membrane. So that's what we are saying. So there is a space which was between the exochoremic membrane and the cytotrophoblasts. So the hypoblast cells are the one which starts to fill in that space. Okay. After they fill in that space, they form a membrane, or they form an area which we call the extra embryonic mesodem. Extra embryonic mesodem. Now, the extra embryonic mesodem, those are actually cavities in the mesodem itself. Okay, so they actually join to form the those same extra embryonic mesodem. They join to form the extra embryonic or the chorionic cavity. So if you have seen here, we have the extra embryonic mesodem and here the extra embryonic mesodem. So this means that the extra embryonic mesodem actually uh, it becomes distinguished in two different mesodems. Okay, that's what we are saying. The extra embryonic begins to divide or is distinguished into two cells. Then the cavities of the mesodem, we are saying they are known as the extra embryonic or the chorionic cavities. Okay, so remember this where the pointer is. That's where the extra embryonic mesodem is, and the cavities of the extra embryonic mesodem, we are saying it is the extra embryonic or chorionic cavity. That's what we are saying. Okay, then this same extra embryonic mesodem has two distinguished layers. Number one, we have the somatophoric mesodem, and you have the sprachnophoric mesodem as well. Okay, so that's what we are saying. Remember, at first we only had the primitive, the extra embryonic, the exochoremic membrane, which was here. Then the cells, we are saying they started to form an extra embryonic mesodem, the one which is outside here. So this cavity is still called the primitive yolk sac. Then the below here, you have seen that the cells that were surrounding the site, that were in the site of trophoblast and the surrounding exochoremic membrane, they had formed a mesodem. Specifically, we called it the extra embryonic mesodem. Then the extra embryonic mesodem had cavities, and at cavities, the extra embryonic mesodem had of course cavities in it, and they are the one which joined to form the extra embryonic or the chorionic cavity. Then this is when now the membrane itself was later distinguished into two mesodem layers of the somatophoric mesodem layer and the sprachnophoric mesodem layer. So in short, we have the extra embryonic somatophoric mesodem, and you have the extra embryonic sprachnophoric mesodem. So that at least you won't forget to say, okay, when we add the extra embryonic sprachnophoric mesodem, or when you also say extra embryonic somatophoric mesodem. So you know, okay, so those were the mesodem layers that were later distinguished. Okay, so that is the 11 to 12. This is what happens during the 11 to 12. Then let's go to the 13. So the surface defect is completely healed, and of course, remember, we are talking about the surface defect in the endometrium, of course. So of course, someone might even be bleeding, and the bleeding may be even be confused for menstruation. Okay, and at this point in time, this is where someone, of course, will even think to say, maybe they are not even pregnant. Okay, because they think, no, I'm having now menses. Okay, but alas, it was just bleeding due to the surface defect. Due to the surface defect. Then next, we have the cytotrophoblast cells which protrude into the cytotrophoblast to form the primary villi. Okay, then the cells are derived from the hypoblasts. Then the cells that were derived from the hypoblasts form the definitive yolk sac, and portions of the remaining primitive sac form the exochoremic cysts in the chorionic cavity. Then the somatophoric mesoderm, which is known as the chorionic plate. Then the mesoderm, the mesoderm traverses the cavity only at the connecting stalk, which is the future umbilical cord. So now let's try to explain this using the pictures. So you have to pay attention to the pointer where I'll be pointing most of the things. Remember, we're talking about the surface defects, which is of course in the up above the upper parts. If you have seen, they have progressed. Okay, so this is when they have become completely healed, and of course someone might experience bleeding, which might be confused for menstruation. Then remember, we said we have the trophoblasts. Specifically, we have the syncytiotrophoblasts and the cytotrophoblasts. So what we are just saying at this point is that the cytotrophoblasts, they are going to invade inside the syncytiotrophoblasts. I'm sure you have seen they have started going inside the syncytiotrophoblasts. This is what we call invasion, the trophoblastic invasion. Okay, so after they start invading, they actually protrude into the syncytiotrophoblasts to form the primary villi. So I'm sure you have seen the primary villi, which is here. Okay, so they form what we call the primary villi. Then the cells that were derived from the hypoblasts, the cells that were derived from the hypoblasts are going. So the hypoblast, remember, we have the epiblast, which was here, and the hypoblast, which is on the lower part. So the cells that were derived from the hypoblast, the one which we are talking about, they are the ones which are going to form the definitive yolk sac. They are going to form the definitive yolk sac. So the definitive yolk sac will be formed. This is the secondary yolk sac, which is here, this one. And the portions of the remaining primitive sac is going to form the exochoremic cyst. So remember, you have formed our secondary yolk sac, which is the definitive yolk sac. Then remember the remnants, the remaining primitive sac, which is here, becomes the exochoremic cysts inside in the chorionic cavity. That's what we are saying. Okay, next, this is where we have the somatophoric mesoderm, which is known as the chorionic plate. So at this point, the extraembryonic somatophoric membrane becomes the chorionic plate. Okay, then the mesoderm traverses the cavity. The mesoderm traverses the cavity only at the connecting stalk, which will be our future umbilical cord. So where is the connecting stalk? The connecting stalk is here. So this is the connecting stalk. So meaning this is the stalk that is holding together the secondary yolk, the amniotic cavity. So that's where the that's where the mesoderm traverses the cavity. That's where we are pointing. Okay, so this is what happens during day 13. Okay, this is what happens during day 13. Okay, so this is the overview of the second week. Overview of the second week. But good part, I'm not going to go through the overview. I have something special for you. So this will be our tutorial for the second week. Will be our overview, like at least you are able to see what exactly is happening. Okay, so
Implantation of the blastocyst usually occurs 6 to 8 days after fertilization. By the end of day 8, the blastocyst has burrowed into the endometrium of the uterus. At this time, it is composed of two main components: the outer cell mass, the trophoblast, and the inner cell mass, the embryoblast. As the trophoblast makes contact with the endometrium, it differentiates into two layers: an inner cytotrophoblast and an outer syncytial trophoblast. The embryoblast differentiates into a bilaminar embryonic disc composed of two cell layers, the hypoblast and the epiblast. Soon after the embryonic disc has formed, a cavity begins to appear between the epiblast and the cytotrophoblast, known as the amniotic cavity. Cells originating from the hypoblast begin to migrate, forming a thin membrane, which covers the inner surface of the cytotrophoblast. This is called the exocelomic membrane. The exocelomic membrane and cells of the hypoblast together form the walls of the primitive yolk sac. By day 9, the blastocyst is completely embedded in the uterus wall. At this stage of development, the growth of the syncytial trophoblast and cytotrophoblast is much quicker than the bilaminar embryonic disc. Small holes called lacunae begin to form in the syncytial trophoblast as it continues to expand. By day 12, the lacunae stop growing and fuse to form large interconnecting spaces called lacunar networks. Capillaries in the endometrium surrounding the developing embryo dilate, forming maternal sinusoids. As the syncytial trophoblast continues to expand, enzymes begin to erode the lining of the sinusoids and uterine glands, allowing maternal blood and uterine secretions to flow into the lacunar networks, establishing a utero-placental circulation. The blood and uterine secretions only come into close proximity to the embryo, allowing the exchange of gases and metabolites. Around the same time, a new population of cells appear between the inner surface of the cytotrophoblast and the outer surface of the primitive yolk sac, known as the extraembryonic mesoderm. Large cavities begin to appear in the extraembryonic mesoderm. These gradually fuse to form one single cavity, called the chorionic cavity. Around 13 days after fertilization, a large portion of the exocelomic cavity is pinched off, forming a smaller cavity, the secondary yolk sac. By the end of the second week of development, the chorionic cavity enlarges, and the bilaminar embryonic disc is joined to the trophoblast by a band of extraembryonic mesoderm called the connecting stalk, the future umbilical cord.
Okay, so I'm sure you have understood what was happening. So in summary, the implantation of the blastocyst is completed during the second week of development. So during this time, a bilaminar embryonic disc is formed, which is composed of the hypoblast and the epiblast. Then a number of extraembryonic structures are also formed during this week. Then the bilaminar embryonic disc gives rise to the germ layers that form the organs and tissues of the embryo. Then a uteroplacental secretion is established as blood and uterine secretions flow into the lacunar network. Then the extraembryonic structures are formed. Specifically, we are talking about the amniotic cavity, the amnion, the umbilical vessels, which is the yolk sac. Then you have the connecting stalk and the chorionic cavity. But of course, this is just a summary. If you want to go back to the demonstration, to the illustration a video, you have to just rewind the tutorial video so that at least you are not behind on the second week and what was happening in the second week. So meaning I'm giving you time to go back to just rewind the video, but at least you again watch the illustration so that as we are going to the third week, you don't get left behind. Okay, so third week. So in the third week, there is what we call the most characteristic event of the third week, which is the gastrulation. So gastrulation is the establishment of the three embryonic germ layers, specifically the ectoderm, the mesoderm, and the endoderm. So this one begins with appearance of the primitive streak, where we have the epiblast cells, where the epiblast cells migrate towards it, detach and sleep beneath it. So this is what we call invagination. Okay, so let's now explain the procedure with the diagram. So what we are just saying is that in the third week, there is a most characteristic event which happens in this stage. That one is called the gastrulation, where we have establishment of the three embryonic germ layers, specifically the ectoderm, the mesoderm, and the endoderm. So where do these ones come from? So of course they begins with the appearance of the primitive streak. So this is what we call the primitive streak. Okay, where after that the epiblast cells migrate towards this same primitive streak. We are saying the epiblast cells, these ones are going to migrate towards the primitive streak, and they detach from it, and they sleep beneath it. That's what we call as the invagination. Okay, so this is our introduction. So let's go. So gastrulation, remember we said the primitive streak is formed from the proliferation and migration of the epiblast cells to the median plane of the embryonic disc. That's what actually forms the primitive streak. The proliferation and migration of the epiblast cells, the median plane. Okay. Then the streak elongates by addition of cells to its caudal end, while its cranial end proliferates to form the primitive node. Okay. Then meanwhile, a narrow groove, which is a primitive groove, appears in the primitive streak, which is continuous with the primitive pit, which is a depression in the primitive node. Then the streak disappears by the end of the fourth week. So what we are just saying is that this same primitive streak was actually formed from the proliferation and migration of the epiblast cells towards the median plane of the embryonic disc. Okay, then the streak continued to elongate. This primitive streak continued to elongate to its caudal end, while its cranial end proliferates to form the primitive node. So this is the cranial end that has formed what we call the primitive node. Then meanwhile, a narrow groove, which is the primitive groove, which is this part, appears on the primitive streak, which is continuous with the primitive pit, which is the depression in the primitive node. So meaning there was a depression in the primitive node, and is the one where the narrow groove actually has become continuous with. Okay, the narrow groove, the primitive groove in the primitive streak. Then the streak actually disappears by the end of the fourth week. So meaning it happens after, of course, the gastrulation stage. Then next is that those invaginating cells that displace the hypoblast cells, that displace the hypoblast, form the endoderm and fill the lining of the yolk sac. Then those that remain in the epiblast form the ectoderm. Then those that lie between the ectoderm and the endoderm form the mesoderm. So here comes the explanation of the picture. So what we are just saying is that, remember, we are talking about the primitive streak and the primitive node, and finally we are talking about the invaginating mesodermal cells. So now those cells, since they are invading the epiblast and the hypoblast, so what you are going to know is that there are cells that are going to displace the hypoblast. So remember, we had the epiblast here. Pay attention to the point. We have the epiblast and the hypoblast. So we are saying number one, those invading cells that displaces the hypoblast. The one that displaces the hypoblast forms the endodem. Okay, which is fills in the lining of the yolk sac. So the invading mesoderm cells that displaces the hypoblasts are going to form the endodem and fill the lining of the yolk sac. This is the lining of the yolk sac. So these invading mesoderm cells are going to they are going to replace the hypoblast and together line the yolk sac. Then they will be called the endodem. Then there are those ones that actually remain in the epiblast. These ones, the ones that remain in the epiblast. Remember, they were invading it. So the ones that remain in the epiblast are going to form the ectodem. So now we have two. We have the endodem and we have the ectodem. What about these ones that are lying in between the ectodem and the endodem? These ones that are in between, what are they going to form? These ones are going to form the mesodem. Okay, so that's what has happened. Let's go. So next is the precaudal plate. So this is a small circular area of the endodermal cells in the lining of the yolk sac, where the ectodem and endodem are in contact and is involved in the forebrain induction. So the precaudal plate is the primordium of the buccal-pharyngeal membrane located at the future site of the oral cavity. So that's what we are saying. So remember, we have the precaudal plate. So this part, that's the precaudal plate. This is actually just a small circular area of endodermal cells in the lining of the yolk sac. So in the lining of the yolk sac, so this is the what just referred to as the precaudal plate in the lining of the yolk sac, where we have the ectodem and the endodem in contact and is involved in the forebrain induction. Then this same precaudal plate is the primordium of the buccopharyngeal membrane, which will be located at the future site of the oral cavities. This is just what we are saying here. Okay, let's proceed. Okay, let's go to formation of the notochord. So the notochord is a solid cord extending the length of the embryo. Initially acts as the primary inducer in the early embryo, but later degenerates entirely except in the nucleus pulpus. So this is formed from the prenotochordal cells migrating through the primitive pit towards the precaudal plate, forming the notochordal process. So which is just the process which is between the ectodem and the endodem. Then you have the primitive pit which extends into the process, forming the notochordal canal. So let's try by all means to see this in the pictures. Okay, so we are saying this same notochord is just a solid cord extending the length of the embryo. Okay, from the cranial end to the caudal end. So initially this same notochord initially acts as the primary inducer in the early embryo, but later will degenerate entirely except for the nucleus pulpus. Okay, that's what we are saying. Then this same notochord is formed from the prenatal caudal cells which were migrating through the primitive pit, this part on the primitive pit, okay, towards the precaudal plate, forming the notochordal process. So this, after they migrated towards the primitive pit, they form the notochordal process. Okay, I'm sure you have seen here. Okay, so which is between the ectodem and the endodem. Then the primitive pit started to extend into the process, forming the notochordal canal. The primitive pit, I'm sure you have seen, it was very small here. Pay attention to the pointer. The primitive pit was very small here, and here it was started to extend. And even on this part, it has even extended largely, and it has now formed the notochordal canal. So we are done on this one as well. Then the flow of the notochordal process fuses with the underlying ectoderm, with the underlying endoderm. Then the fused layers show degeneration, forming openings which later eliminate the flow of the process. Then the notochordal canal, which is continuous with the primitive pit, now also communicates with the yolk sac, forming the temporary neuroenteric canal at the primitive pit. Remember, we said the primitive pit was actually continuing to elongate, and it formed the notochordal canal. Remember, that's what we were talking about, okay? The notochordal canal. Then the flow of the notochordal process, this same process, is actually going to start infusing. I'm sure you have seen the lines here. They are infusing with the underlying endoderm. Then the fused layers actually are going to later degenerate. I'm sure you have seen they have now degenerated here, meaning they are not seen, okay? Forming the openings which later eliminate the flow of the process. So the flow of the process has been eliminated, just now lying there. Okay, so the notochordal canal, which is in continuous with the primitive process, now communicates. I'm sure you have seen the notochordal canal, which was elongating from this side, is now just communicating with the primitive pit. Also now communicates with the yolk sac. So they're just communicating to each other. So now what they have formed is what we call the neuroenteric canal. The arrow, I'm sure I've seen with the arrow. That's the neuroenteric canal at the primitive pit. We are also done on the formation of the notochord. Then let's go to the continuation of the formation of the notochord. So the cells of the notochord plate, which are the remnant of the process, proliferate and combine to form the notochord craniocaudal, which detaches from the refined endoderm. Okay, so we are saying that the cells from the notochord plate, okay, which were the remnant of the process, were actually going to combine and form the notochord craniocaudal, okay, which detaches from it. So it's a notochord for this is an notochordal plate which is infolding, okay, and refuse the endoderm. This is formation of the continued. Then let's go to the cloaca membrane and the allantois. So the cloaca membrane resembles the buccopharyngeal membrane in structure. So this is the endoderm, the ectoderm and the endoderm in contact with no intervening mesoderm, which will be our future opening of the anus. That's the cloaca membrane. Then the allantois, also called the allantoenteric diverticulum, appears on the 16th day as a posterior extension of the yolk sac into the extraembryonic mesoderm, meaning on the adult remnant is the median umbilical ligament, sometimes involved in congenital bladder abnormalities. So those are some of the things we are saying, okay? Those are some of the things, or those are the definitions, or those are the descriptions of the cloaca membrane and the allantois. Okay, so let's go to the fate map of the invaginating cells. The fate map of the invaginating cells. So the region of the primitive streak through which the epiblasts migrate leads to an ultimate fate which has been determined and mapped out. Okay, so we have the cranial part of the node, it becomes the notochord. So the cranial part of the node becomes the notochord. Okay. Then the lateral parts of the node plus the cranial part of the streak will become the paraaxial mesoderm. Then the mid-streak region becomes the intermediate mesoderm. So this is what we're talking about. The node becomes the notochord. The lateral aspects plus the cranial part will become the paraaxial mesoderm. Then next we have the median region, which is this middle region. It will become the intermediate mesoderm. Then they have the caudal part of the streak, which becomes the lateral plate mesoderm. The caudal part of the streak will become the lateral plate mesoderm. Then you have the caudomost part of the streak. Caudomost part meaning the caudomost part of the streak, which is here, will become the extraembryonic mesoderm. Then that's it. Then you also have to note that the extraembryonic mesoderm has dual origin. So from the exocolemic membrane, which is from the hypoblasts, then also from the epiblast cells migrating through the caudomost part of the primitive streak, which traverse the boundary of the embryonic plate. So those are the two dual origins of the mesoderm, of the extraembryonic mesoderm. So this is the fate map of the invaginating cells. So let's go to the extraembryonic mesoderm. So this is the extraembryonic mesoderm. So this number one part is the primitive groove. The second part is the primitive pit. And the third part is the primitive node. So this part is the primitive node. Then the fourth part, which is here, is the buccopharyngeal membrane. Then the fifth part is the cardiogenic field. Okay, this is the cardiogenic field. And the sixth part is the cut edge of amnion. Then the seventh part is the extraembryonic mesoderm. So this is the extraembryonic mesoderm. Then the eighth part is the endoderm. Then the ninth part is the cloaca membrane, which later, of course, from the anus, the opening of the anus. Okay, so that's the extraembryonic mesoderm. So let's go to the shape of the embryonic disc. So the embryo is initially flat and almost round. Then later it becomes elongated and broad at the cephalic region due to the migration of the cells through the primitive streak. Okay, so that's what we are saying. So the embryo is initially flat. Okay, but due to migration of the cells in the primitive streak, it actually becomes elongated, okay, and broader at the cephalic region. So it becomes elongated and broader at the cephalic region. So because of the continuous migration of the invaginating cells in the cephalic direction, cranial germ layers begin differentiating by the middle of the third week, whereas that of the caudal layers begins by the end of the fourth week. Hence, the embryo develops craniocaudary. So, meaning the embryo develops from the cranial part, then caudary. Since you are saying in the cranial region, they differentiate by the middle of the third week, whereas the caudal region begins by the end of the fourth week. So, hence, the embryo develops craniocaudary. So, meaning from the head and on the the posterior portion or the inferior part specifically. Okay. That's caudal inferior. So that's what we are saying on the shape of the embryonic disc. Then let's go to the growth of the villi system. So remember, we had the primitive villi, which were formed early in the third day of the development. Next, we're going to have will be our secondary villi, which are formed when the extraembryonic mesoderm penetrates the core of the villi towards the wall of the uterus at the site of the future placenta, which will be called the pseudo basalis. Then we also have tertiary villi, which are formed when some of the extraembryonic mesoderm cells in the villus cores differentiate into blood vessels and small blood vessels. Okay, differentiate into blood cells and small blood vessels. Okay, not blood cells and not blood vessels and small blood vessels. So differentiate into the blood cells and the small blood cells and small blood vessels. So remember we are talking about the primary villi, you have the secondary villi, and you have the tertiary villi. So these are actually villus capillaries. Okay, then here we have the mesoderm core. Okay, so this is the growth of the villus system. So let's continue. So in the growth of the villus system, in the meantime, the cytotrophoblast cells penetrate deeper and reach the maternal endometrium, where they establish contact with each other and form a thin outer cytotrophoblast shell. Then the villi that extend straight from the chorionic plate are actually stem or anchoring villi. Then those that arise from the stem villi are called the free or the terminal villi, through which exchange occurs. Okay, so what we are just saying is that we have the villi that we are penetrating, we are the cytotrophoblast, cytotrophoblast cells, which we are penetrating deeper and reach the maternal endometrium, where they establish a contact with each other and form the outer cytotrophoblast shell. So this is the outer cytotrophoblast shell. Then the villi that extend straight from the chorionic plate. The villi that extend straight from the chorionic plate. This is the chorionic plate. Are known as the stem or the anchoring villi. Then those that are arising from the stem villi itself, from the stem villi itself, will be known as the free or the terminal villi, through which the exchange is going to occur. That's what we are saying. Then finally, the blood vessels in the tertiary villi will join the blood vessels in the chorionic plate, which is the successor of the somatoprodic extraembryonic mesoderm, and in the connecting stalk, which in turn join the extraembryonic blood vessels. Then the heart begins beating in the fourth week. Okay, so after the blood vessels, specifically the tertiary villi, will join the blood vessels. This is the tertiary villi are going to join the blood vessels in the chorionic plate and the connecting stalk. So meaning the blood vessels in the tertiary villi will join number one the chorionic plate and the connecting stalk. So meaning the blood can actually flow. And that's why we are saying at the end of this, the heart begins to beat in the fourth week. That's like the first organ that forms and start beating or functioning. Okay, so the heart starts to beat in the fourth week after the connection has been made, after the villus system has been made. So this is the extra embryonic secretion after it has been made. If you have seen the connecting stalk, the tertiary villi all connecting together. Okay. Then let's also do our summary of the third week, which is our gastrulation week. So there are three primary germ cell layers that are formed, which provide cells for organ formation in the following months. So this is a summary you have to pay attention.
During the third week after fertilization, the 3 primary germ layers are formed, which provide cells for organ formation in the following months. These germ cell layers are formed by a process known as gastrulation, which involves rearranging epiblast cells. As cells from the epiblast migrate, a faint groove, called the primitive streak, forms on the surface of the embryonic disc. With the formation of the primitive streak, it is possible to recognize the head and tail ends of the embryo. Some epiblast cells migrate, differentiate, and then replace the hypoblast to form the endoderm germ layer. Other epiblast cells migrate and differentiate to form a new layer between the epiblast and hypoblast, identified as the mesoderm germ layer. The remaining epiblast cells become the ectoderm germ layer. The result of gastrulation is the formation of the trilaminar embryonic disc, consisting of the 3 germ layers. The ectoderm gives rise to all nervous tissue and the epithelium of the skin. The mesoderm gives rise to blood, muscle, bone, and connective tissue. The endoderm forms into the epithelium of the gastrointestinal tract, the respiratory system, and many organs.
Okay.
Further differentiation of mesodermal cells begins the formation of the notochord. The notochord is important in starting or inducing the specialization of other cells, including those directly above them, called the neural plate. Epiblastic cells in the neural plate are induced to begin to mound up and fold into a groove. The neural groove continues to fold. Adjacent notochord mesodermal cells are induced to form somites. Somites are the eventual source of cells that form muscle tissue, skeletal, and other connective tissue. The neural groove completely folds inward to form the hollow neural tube. The neural tube arises and its cells eventually develop to form the brain, spinal cord, and other parts of the nervous system. Also during the third week, mesodermal cells from the primitive streak rearrange to form blood vessels in the embryo, and a primitive heart tube is formed. Continued development of the chorion results in the formation of the chorionic villi, projecting into the endometrium to form an exchange area called the intervillous space. The maternal blood vessels and fetal blood vessels remain separate, so maternal and fetal blood do not normally mix. However, oxygen, antibodies, nutrients, and waste products are all exchanged via the intervillous spaces.
Okay, so I'm sure you have seen the summary of the third week. And the reason why I like to do this is because, general embryology on its own is something which, of course, you can read. But for me, I feel most of the things are very microscopic to imagine. Okay, so unless you see it, oh, this is how the notochord and they are so without actually a drawing, without a picture, it's very difficult to imagine it. Okay, because you might just be imagining something which is entirely wrong. But if you see a picture of the notochord differentiating to the neural plate, then you'll be like, oh, okay, that's happening. It's the epiblasts being filled with the invaginating cells, forming the ectoderm, mesoderm, endoderm. Those are some of the things that's going to help you know general embryology. Okay, those are some of the things. Okay, so let's go to the clinical connection. So the neurotube defects are actually caused by arrests of the normal development and closure of the neural tube. These include number one of the spinal bifida, which is a congenital defect of the vertebral column in which the lamina of the L5 and or S1 fail to develop normally and unite at the midline. Then the least serious form is called the spinal bifida occulta, which occurs in L5 or S1 and protrudes with no symptoms. Then the only evidence of its presence is a small dimple with a tuft of hair in the overlying skin. So several types of spinal bifida involve protrusion of meninges or the membranes and or the spinal cord through the defects in the lamina and are collectively termed spina bifida. I don't know why I like to say spinal bifida. Spina bifida cystica because of the presence of the cyst-like sac protruding from the backbone. So if the sac contains the meninges from the spinal cord and cerebral fluid, the condition is called the spina bifida with a meningocele. If the spinal cord and its nerve roots are in the sac, the condition is called spina bifida with meningomyelocele. That's the first neurotube defect. Then you also have other cases, for instance, a neurotube defect in anencephaly, which is of course means without brain. So the cranial bones fail to develop and certain parts of the brain remain in contact with the amniotic fluid and degenerates. So usually a part of the brain that controls vital functions such as breathing, regulation of the heart is also affected. So infants with anencephaly are still born or die within a few days after birth. The condition occurs about once in every 1,000 births and is 2 to 4 times more common in female infants than in male. So this is the spina bifida, which is caused by failure of the lamina to unite at the midline. So the reason why usually this occurs, or neurotube, if you want to prevent neurotube defects, you find that mothers usually have a folate deficiency. So those are some of the things you need to ask the woman if the child is born with spina bifida, if maybe she was taking folate or not. So this usually occurs, so neurotube defects occurs due to folate deficiency. Then sometimes let's look at the tumors associated with gastrulation. So sometimes remnants of the primitive streak persist in the sacrococcygeal region. So these clusters of the pluripotent cells, factors of the pluripotent cells proliferate and form tumors known as the sacrococcygeal teratomas that commonly contain tissues derived from all three germ layers. So this is the most common tumor in newborns, occurring with a frequency of 1 in 37,000. These tumors may also arise from the primordial germ layers that fail to migrate to the gonadal region. So this is an example of a sacrococcygeal teratoma resulting from the remnants of the primitive streak. These tumors may become malignant and are most common in females. Okay. And then you also have other abnormalities. So of course, this one is still sacrococcygeal teratoma, probably resulting from the remnants of the primitive streak. Then these are some of the things. Things we are talking about. Then we also have other conditions such as these ones. So these ones are two examples of what we call cyanomaria, which is termed caudal dysgenesis, where we have the loss of the mesoderm in the lumbosacral region resulted in the fusion of the limb buds and other defects. So here we have caudal dysgenesis now, where there is loss of the mesoderm in the lumbosacral region which resulted in fusion of the limbs, buds, and other defects. So these are also some of the other conditions, meaning there are actually other conditions which can occur in the third week. So we are now done with the tutorial, and this is our checkpoint. So there are questions where they ask you to explain the formation of the notochord. Specifically, usually they like to explain gastrulation, where they just give you an essay where you have to write about gastrulation. Specifically, that's third week, the most event of the third week, characteristic event of the third week. Okay, so we are done with our tutorial. Thank you for watching. If you haven't subscribed, subscribe and the bell notification. If you have any question, just hit the comment section in the tutorial video and ask the question that you want. Otherwise, it's the end of the tutorial. Thank you for watching once again. See you on the next tutorial video on embryology. This is our lesson 2. We are going to have a 5 lesson series. This is our lesson 2. We have remaining 3 lessons. So next one is lesson 3.